Hello friends, welcome you all at Indian Institute of Learning Life Saving Skills. Today we are there with you to discuss the typical case scenarios and that you used to get in your day-to-day practice when you are sitting in your emergency and casualty and tries. So case discussion was the topic is acute abdomen. As all of you know, acute abdomen is a magic box. Acute abdomen is a magic box. Even after the intelligent investigations and thorough clinical examination, sometimes we are failed to diagnose the patient exactly, and lastly the patient will end up into diagnostic laparoscopy because everything comes out to be the negative point of view and the patient will be having the persisting symptoms. So we are here to discuss most important case scenario today is acute abdomen. Under that is acute pancreatitis. How the patient comes to us in emergency department and how we have tried to diagnose and how we have evaluated the patient and what was the working and provisional diagnosis and what was the later final diagnosis at the time of discharge. A young gentleman, 36-year-old male, presented in emergency with severe pain abdomen, epigastric in the morning it was, and later it has shifted to the right lower quadrant. And on arrival the patient was normotensive, afebrile, saturation was maintaining 95 plus at room air, and the patient was running slight tachycardia because of pain. And the patient initially evaluated and abdomen examination was suggestive of rebound tenderness in McBurney's point, and there was a tenderness along with rebound tenderness in the McBurney's point along with slight tenderness in the epigastric region. Bowel sounds were present. Abdomen was slight tense. Chest examination, cardiovascular and respiratory system was non-contributory. There was, except the running, slight tachycardia, nothing else. The patient was sweating profusely. ECG and serum monitoring blood glucose SMBG was done. It was found to be normal. In view of the clinical examination, the patient working diagnosis was made was acute appendicitis. The working diagnosis of patient was acute appendicitis and investigations were sent. Patient kept NPO and intravenous fluid and antibiotics and supportive treatment was started. Patient kept NPO. By the time after a few hours the investigations arrives, investigations were suggestive. The CBC was suggestive of leukocytosis and there was a mild thrombocytopenia. Rest of the investigation found to be normal, which are renal function test and liver function test along with serum amylase were done, which came out to be normal. In view of leukocytosis and the patient clinical examination was suggestive of rebound tenderness in the McBurney's point, patient suspected to have acute appendicitis and patient was set for radiological investigation and the modality of choice was ultrasonography. Ultrasonography interestingly found came out to be normal except the fatty liver, as the patient was slight occasional drinker twice or thrice a week and USG came out to be fatty liver except that it was normal and patient was having persisting pain. So here is the case how it was. Earlier we have suspected to have acute appendicitis in view of leukocytosis, the blood markers and clinical examinations of McBurney's tenderness along with the rebound tenderness patient was having. Then later what we have found out that on day second patient was having persisting pain abdomen and serum amylase was repeated and serum amylase was 300 plus, and on successive day again the serum amylase was repeated and so this is how the case presented earlier and later diagnosed to have the something else and came out to be acute pancreatitis. And on successive days there was a spike or increase in the serum amylase level and which later used to settle down from day 4 to 5 and patient discharged back with the slight raised serum amylase levels and patient was passing stools and flatus and patient symptomatically orally tolerating well liquid and fat free diet. So this is how the case presented in emergency and later diagnosed to have this. So the moral of the story from this case discussion is very simple and straight away. In earlier phase of even acute pancreatitis, serum amylase level can be normal. One thing. In cases of chronic pancreatitis, serum amylase level can be normal in early phase. Acute on chronic pancreatitis, serum amylase level can be normal in early phase or at the time of admission. The levels of serum amylase does not correlate with the severity of acute pancreatitis. Sometimes what happens, serum amylase levels will be very high and pancreatitis will be very mild. So there will be no correlation between the levels of serum amylase and the levels of the severity of the pancreatitis. Sometimes there will be mild pancreatitis and levels will be too high, and sometimes it will be acute necrotizing, or sometimes acute on chronic pancreatitis, serum amylase level will be slight high or it will be subnormal. So this is how the case presents in the emergency and how we need to correlate. So for early new learners, this helps a lot. You suspect something and comes out to be something. So when in view of acute abdomen, we should have a wide view, and until we'll make the confirmed diagnosis, early markers sometimes comes out to be normal. So we need to repeat it after sometimes. Serum amylase, sometimes what happens, there will be non-pancreatic tissues which increases more levels of serum amylase. So we has to sometimes, if available in your lab, we have to send for P amylase, pancreas specific amylase. Then we'll get the accuracy, which approximate counts from 15 to 17% of the total non-pancreatic amylase. That gives the severity. Other markers you can send what is CRP levels along with the serum lipase levels, that too. But in acute pancreatitis, earliest marker increases is slightly amylase. So be in touch with the different kind of case scenarios which are peculiar in the presentation in emergency department and comes out to be something else what we suspect on our clinical examinations and on the patient history. So be in touch. So this was the presentations of acute abdomen. The patient suspected to have acute appendicitis along with the investigations, and later comes out to be something else in view of persisting pain abdomen. Later it was patient settled down and sent back home. So be in touch with Indian Institute of Learning Life Saving Skills if you are a learner and you want to learn the clinical skills. So we will develop you and we will make you train. Thank you very much. Be in touch. Have a good day. Thank you.